Sure, my name is McClure. I'm from Cornell Medicine in New York City. So focal therapy is where you target just one specific area within the prostate to treat it, whereas radiation therapy, you treat the entire prostate to deliver therapy that way. So when looking at focal therapy versus radiation therapy for efficacy, there's never been a trial that's compared the two. We know that radiation therapy is an established therapy for prostate cancer. It's in guidelines. Focal therapy is yet to reach guidelines, but in the appropriately selected patient, it may provide sufficient oncologic outcomes for patients. Prostate cancer treatment, unfortunately, is associated with either urinary dysfunction, such as incontinence, or increased urinary frequency or urgency, sexual dysfunction, such as erectile dysfunction, or even GI toxicity when you look specifically at radiation therapy. So each treatment modality has their own kind of side effect profile associated with it. The aim of focal therapy is really to reduce those side effects that we see with definitive therapy, such as surgery or radiation. And so the outcomes from focal therapy really is to decrease the sexual and urinary dysfunction and GI toxicity that can be associated with radiation therapy. So the recovery period for either focal therapy or radiation is dependent on which treatment is given. So with focal therapy, usually there's an acute recovery period where you may need a Foley catheter for a short period of time, and then usually within about 1 to 3 months, patients return to their baseline fairly quickly. With radiation therapy, the impact of that treatment on a man's health tends to be acute in the first 1 month to 3 months, and it can take sometimes up to a year before patients start recovering back to their baseline with regards to urinary and sexual function from that perspective. Yeah, there's some thought that with focal therapy failure, if that does occur, that you can retreat a patient with another focal therapy, or if it recurs after an initial treatment, then you can go straight to radiation or surgery afterwards. Risk stratification is exceedingly important for deciding who is a good patient for focal therapy. Patients with low-risk prostate cancer really shouldn't be treated, and those patients can be watched with close active surveillance. High-risk prostate cancer patients are not good candidates for focal therapy because those tend to have high failure rates. So the kind of sweet spot for focal therapy is patients with intermediate-risk prostate cancer. The risk of recurrence after focal therapy really depends on A, the modality that's being used, and B, the experience of the provider doing that therapy. That being said, the recurrence rates can be quite high with focal therapy. In some studies, they may approach 40% at 2 years. Focal therapy is still in its infancy when compared to radiation therapy. Radiation therapy has been around for decades. There's been large randomized control trials comparing radiation and surgery, and we don't have that yet with focal therapy. That being said, the trials and prospective studies that have been done showing the efficacy of focal therapy are promising, and it's likely that focal therapy will be in the treatment algorithm for patients with prostate cancer.